Thank you so much for joining us today. We really appreciate you taking the time. It's my great pleasure to introduce Dr. Andy Huang. When we learned that our community was really interested in vitro fertilization and pre-implantation genetic testing, I immediately thought of Dr. Huang. He's an obstetrics gynecologist who has specialized in reproductive endocrinology as well as in vitro fertilization. And he's a longtime friend and colleague of mine. In fact, he and I met at UCLA in a stem cell research lab, working side by side together. And it's just a great pleasure to be able to connect with him again and find new meaningful collaborations through a webinar like this. So I know we'll all learn a lot from you, Dr. Huang, so thank you so much for joining us today.
Thanks for having us. First and foremost, that as we talk about planning families, is that there are options. So it's not just one option, and it doesn't have to be directed towards the fertility option of IVF with genetic testing. That adoption, that using egg donor or sperm donor are many options. So I think that's important. And today I'll talk about, the one option that's related to kind of my specialty, which is fertility, but by no means is that the only option. A second important thing that Kayla brought up was that this is truly a multidisciplinary field, that we have scientists, and this is where kind of the RUNX1 research program has brought us together. We have scientists, we have geneticists, we have oncologists, we have fertility specialists. So it really is a multidisciplinary field, and I think it's important for us to recognize and continue to work together in that front. And the last thing that I wanted to just emphasize was that, and ultimately, any decision on how to grow a family is a very personal and family decision. So while the multidisciplinary team is there to help everybody kind of with those decisions, really our goal and our job is to provide options and help the families kind of decide on what's best for them. So again, my specialty is on the fertility side. I am blessed to be in a practice here in Southern California. I'm at Reproductive Partners, and we have multiple offices here. Next slide. So IVF is something that we've been doing as fertility specialists since 1978. So we've been using it for decades. To date, there are millions and millions of children born from IVF, and it actually accounts for about 1% to 2% of the world's population these days. Now, IVF may seem very daunting, but here's just a simple kind of schematic that shows kind of the process of IVF from the beginning, where women get ovarian stimulation to help mature follicles so that we can retrieve oocytes. This process of maturing follicles to get the eggs takes about 5 weeks from beginning to end. And then once we get the eggs, then we can fertilize it with sperm. And then we watch the embryo start to develop. And it's at this stage that we can see embryo formation become. Nature a lot of times will weed out some of the bad ones. So we'll watch eggs fertilize. We'll watch these fertilized zygotes then grow on over the course of 5 to 6 days to become embryos. Once they get to a more advanced embryo stage, this is where we can more safely test these embryos for very specific either chromosomal or genetic disorders. Kayla reviewed kind of a very good background about the genetics of autosomal dominant disorders. So we'll talk a little bit about that and how we can work to screen those disorders and try to promote healthy pregnancies and healthy families. Once the PGT testing is done, these embryos are then frozen because it takes a little bit of time to get the results back. When the results get back, we're now able to screen embryos that may carry specific genes and the ones that are non-carriers. Then we can specifically take the non-carriers and carefully transfer one of these embryos back into a woman's uterus to achieve a pregnancy. Next slide. So this is a diagram showing kind of what we can do in our laboratory. And so over the last decades, we've been able to advance kind of what we can do in our laboratory such that we can get the egg, which is the day 0, so that's an oocyte. We put it with sperm, and we watch it fertilize to become a zygote. Over the next 3 days, we watch the embryo start to divide and grow. So it becomes 2 cells and then 4 cells, and then it cleaves again to become 8. In the old days, we used to do testing of embryos on an 8-cell embryo after day 3. And this was prior to advancements in freezing techniques. So in the old days, we would have to test on day 3 when an embryo only had 8 cells. But you can imagine when you use a needle and you puncture the embryo, when you suck out one of those 8 cells, it can actually cause, injury. So we saw that pregnancy rates weren't that good on day 3 biopsies. So as tools in our lab got better, we have taken now day 3 embryos, which have 8 cells, and then they start to more rapidly cleave to become 16, 32, 64. By the time we get to about day 5, day 6, an embryo now has about 100 cells. So it's a more robust embryo. There are 2 cell layers, and we can go to the next slide. And so here is kind of a zoomed in picture of a more advanced embryo. And so this is what we call a blastocyst. It takes about 5 to 6 days to get to this stage. When you get to this stage, the breakdown of the embryo is the zona, which is the outer shell. There's also the trophectoderm, which is the cells on the outside. These are going to these will subsequently become the placental cells. And then the ICM diagrammed here is the inner cell mass, which is going to be the embryo and the fetal cells. So today we can actually thin the zona and then go in and aspirate a few cells from the trophectoderm. And from these cells, we can then send off to do the genetic testing that we want to do. Next slide. And so what are the genetic tests that we can do? Well, there are 3 different types. And we're going to focus on the top, which is the PGT-M, which is looking at very specific monogenetic disorders. In addition to that, though, we can also look at aneuploidy, which Kayla's slide of showing chromosomes is specifically where we're looking at and making sure that there are appropriate pairs of chromosomes. We can also do PGT to look at structural rearrangements like translocations, which are a very common cause for recurrent miscarriages. But one of the great tools that we've been able to utilize is specific to PGT-M. And PGT-M is looking for very, very specific genetic disorders, whether it's autosomal dominant, X-linked, or autosomal recessive. Next slide. So the PGT-M process takes some time. The first important thing is a case review. So when a couple has found out that they are a carrier of RUNX1 or a myriad of other disorders, whether it's Huntington's, SMA, but anytime a couple comes in with a gene specific that has clinical outcomes that they're concerned about, the case is reviewed with geneticists to make sure that indeed a probe can be created. And more than 99% of the times, a probe can be created for that gene, okay? So that case is reviewed. This usually is an initial consultation with the genetics lab that takes 1 or 2 weeks for them to be able to review the gene of interest. And then they begin the preparation of creating the probe. This is a very in-depth process that takes about 8 to 12 weeks. So when a probe has to be created, it's very specific to the mutations of the couple. So for cystic fibrosis or RUNX1, they're able to sequence and find out exactly kind of where the mutation is, and they create a probe specific to that. Then we do the IVF process. That process takes, as I said, about 5 weeks. Once we get the eggs and create the embryos biopsied, and then it takes about 2 weeks to get the results back. And then once the results are back, we're able to screen which are the healthy embryos, which are the unhealthy embryos, and then we'll transfer 1 healthy embryo back into the woman. Next slide. So we've seen the diagram in terms of inheritance. Here on the right side, we're just looking at this is an autosomal recessive model. So in yellow, you can see the gene of interest. But for RUNX1 and autosomal dominant disorders, even one gene can have a 50% affected family rate. So know that here, I'm just showing the diagram in terms of, finding a probe specific to genes. When you talk to the genetics labs, they will tell you that they have a very good success rate in creating probes for specific genes. And it's, again, over 99% of the times they're able to create that specific probe. And it allows us to detect over 95% which embryos will be affected, and so we can very accurately screen for these disorders. Next slide. And the ultimate goal then is to find the healthy embryos that are created from the genetics, the eggs and the sperm, and do everything we can so that we can, screen and eliminate the potential gene of interest so that we can achieve healthy families.
So a couple people have been asking about cost. Right. So basically, can you please discuss the anticipated costs for IVF, PGM, and PGM for families?
So, and there are different, so costs depend on sometimes by states, because some states have mandated coverage. So California is a little bit behind, but there are some more progressive states like New York, New Jersey, Massachusetts, where fertility is covered. How much of it is covered, I'm not sure. I know that when there isn't coverage, that the cost of IVF will probably range about 15 to 20K. The additional testing of the embryos, because not everybody does testing of embryos. So the IVF process kind of alone is probably about 15 to 20,000. And that's because of surgical fees, monitoring fees, medication fees that all add up. These are very expensive, highly purified hormones that we're utilizing to allow multiple follicular development. So about 15 to 20,000 kind of would be kind of the standard out-of-pocket fees. And then about 5 to 8,000 from the genetic side of things to create the probe, to then analyze the embryos. So it is not cheap. Unfortunately, the cost of fertility treatment is a hurdle for many. But there are foundations that are available, and they are uniquely dedicated to the reason why we're meeting today, and that is for cancer risks. So I know that, Live Strong is a foundation that, we take care of a lot of women who get the unfortunate diagnosis of breast cancer. And so they're not ready to start their families yet. And, they may or may not be ready to create embryos, but there are foundations that are very specifically dedicated to helping with alleviating the cost and burdens of fertility care. And so that's something that I'll work with the team here to kind of, come up with a list and have you distribute it to, anybody who's interested.
Perfect. Thank you. And that, we, someone else had a question and it looks like you answered it, that, we're glad to share resources. Very good info. May I ask how many embryos are tested at once? And Andy, you said as many as are created.
Especially because for autosomal dominant transmission, that's going to be a 50% affected rate. So, and this is where age also plays a role too, because the younger you are, the more eggs you have. The more eggs you have, the higher, that 50% kind of inheritance rate. So, age and ovarian reserve are other variables that fertility specialists will really look at in counseling you kind of whether it makes sense. Because when you look at a typical 20-year-old who might easily make 20 eggs, and those 20 eggs will then have, 2/3 will fertilize. So now we're down to 12 or 13 zygotes. We'll watch those grow and mature, and we end up with 5 or 6 embryos. So it's really important to understand the numbers, because there's going to be a natural attrition of eggs to embryos. And when you get to the stage of embryos, if we start with 20 eggs, we might end up with anywhere from 6 to 10 embryos. Of those 6 to 10 embryos, in addition to looking at the gene of interest, we'll also be able to look at chromosomal normality. And for any age woman, there's going to be a relatively substantial subset of embryos that are aneuploid. So that have an extra chromosome 21 that makes it Downs, or extra 13 for Patau syndrome. So while we're looking for a very specific gene of interest, we're also going to screen and make sure that the chromosomes are appropriate. So a 20-year-old could make 20 eggs, end up with 10 embryos. Those 10 embryos will give us 6 euploid embryos, and then only 3 of them might be, right, the 50% of the 6 would be 3 embryos that would be screened for. That's a healthy 20-year-old. So when these discussions are made with geneticists and your healthcare providers early, this is a critical time that we're able to take advantage of the fact that younger women will have healthier eggs that will translate to more embryos to screen for. in contrast, when a 40-year-old comes into the office with a little bit of infertility and a family history of genetic predisposition for cancers, we're now working with 10 eggs. 10 eggs will translate to 3 or 4 embryos. And now the euploidy rate on 4 embryos for a 40-year-old may be 1 in 3 or 1 in 4. So we've gone from 4 embryos to 1 euploid, and then that's a 50% chance of having that autosomal dominant gene. So the better we do at counseling and getting the information out there, that there are fertility options. And again, really critical, what Kayla said is that these are options. If a 40-year-old comes in and her ovarian reserve is low, and the probability of me finding a healthy embryo that is transferable is going to be low, you know, it's really important, because with the cost of fertility, you know, to go through all of this is not easy for many families. So the better we do in terms of counseling and getting patients at an appropriate age to their healthcare providers, whether it's fertility specialists or not, the better odds we have of finding those healthy embryos. So youth plays a critical role in allowing us to find the embryos that are healthy. To answer the question in a long way, the more embryos we have, the higher the probability we'll find that the chromosomally normal and genetically normal embryo.
Great, thank you. And you might see that someone was wondering if these numbers that you're citing are the same for Black, white, Latina, Asian, etc. women.
Age is the best predictor in terms of health of eggs. There might be differences in ethnic kind of, but the differences are very small. So the highest predictor in terms of finding healthy embryos is going to be age.
What are some of the characteristics of a mutation that can contribute to challenges in cases where a probe is not available for IVF?
So that's a great question. So to get an update, I reached out to a geneticist from the laboratory that does the PGT testing. The vast majority of the times, they're able to create a probe. The difficulties are the more generations and the more iterations of the mutations that they're able to assess, the better the probe will be to screen for the gene of interest. So oftentimes in the preparation phase, in addition to sequencing the gene from the family, they like to get other generations of the parents. So the problem with certain probes is that if they're not able to get, multiple, assessments from other family members. So oftentimes when there are other families, members that they're able to screen for, they get the sensitivity of the probe will be better. Now, it also depends gene to gene. There are some genes that are easier to kind of create a probe for. By the way, RUNX1 is a gene that has been screened for. So I did confirm there have been cases of RUNX1 that have already been kind of probes have been created for families. So we know that is a gene that can be screened. Amanda, one more thing is that, infertility is a very personal kind of issue. So anybody who's participating today, if they ever kind of want to reach out kind of privately, you can give them my contact info. You can give them my cell phone. I'm happy to reach out to anybody, to discuss the more personal kind of infertility side of things. But there are options out there for everybody. And so, I think that was really important, because by the time patients come to me, we're focused on just that one option of creating embryos to screen for, but there are other options.
At least one other question came in. If a probe has been created already, can it be reused if it's for a family with the same mutation? That was a really good question.
Yeah, really good question. The laboratory still likes specific probes in case there are any variants in the mutation. Yeah, so if it's the same couple, obviously for a sibling cycle, the probe's already created for that family. That's easy to use. But I know that kind of when we're working with extended family, probes need to be recreated.
And we talked about this yesterday when we prepared for this, right? There are, I forget how many specific mutations in the RUNX1 gene that we're at right now, Katrine? Do you know where we are?
104.
104. So there would need to be a unique probe for each of those, right?
Correct.
Every single mutation you have, a probe needs to be created for it. And then you're saying for a single mutation, that probe could potentially not even be reused or recreated, I guess.
Right, because there are some genetic mutations that have very, very similar kind of cystic fibrosis, a very specific kind of mutation points. But even then, the genetics lab doesn't like to assume anything. They want to create very specialized probe for each unique mutation.